You read my mind. I was just looking at our list, and I know that we do have a few people juggling a number of commitments and able to join as soon as they're able. So let me go ahead and start this meeting for our response subcommittee for the substance use working group. And let's go ahead and call to order and take a roll call.
Okay. Gina Flores O'Toole. Shayla Holmes.
Present.
Christine Payson.
Present.
Dr. Terry Kern.
Present.
Assemblywoman Jill Tolles.
Present.
Dr. Stephanie Woodard.
Present.
Great. Chair, we have a quorum with 5 out of 6 members present.
Okay, fantastic. Thank you so much. And I just want to be sure I have, it looks like Dr. Terry Kearns and Dr. Stephanie Woodard on Zoom, so I can see your video. And I heard Shayla Holmes and Christine Payson say they're present. Are they on the phone?
I am zooming in from my phone. This is
Perfect. That's fine. I just wanted to make sure it wasn't a technical glitch on my end that I couldn't see your faces. So thank you for zooming in and joining us on the phone. All right, with that, I'd like to move to reviewing and approving our minutes from May 9th. And if anyone has any questions or comments, now's the time to raise them.
Actually, sorry, Assemblywoman Tolles, we have public comment first.
Oh, you're right. I jumped ahead. You're right. We can't skip public comment. I know that we have a lot of people very interested in the work that we're doing today. So please let me open up public comment. Do we have anyone requesting public comments either on Zoom or on the phone?
Valerie Quape-Haskin has raised her hand.
Thank you. Please, Valerie.
Thank you so much. For the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. I really appreciate the recommendations. I was able to just breeze through them very quickly. A couple of things that I would like to comment upon is when looking at the crisis response teams and the mobile teams that were discussed in one of the recommendations, also looking at strategies such as FAST or something even more comprehensive for persons who are leaving incarceration or other detention facilities, particularly those with a past history of substance use disorder or substance misuse relating to opioids, just to help us kind of identify and coach those people through those processes. So beyond just the teams, but also really looking at programming to help them reenter the communities in a meaningful way, because it seems like, in particularly at the county levels, that's not necessarily happening across the state. As well as, I know that there's also some other language that we might want to explore, including an NRS relating to the ability to have MDT conversations for comprehensive case management, similar to that is currently written in for ADSD, but unfortunately that is focused on serious mental illness and not necessarily co-occurring conditions or persons with substance use disorder, and is also really focused on avoiding abuse or neglect. So having some mechanism where we can ensure that persons with either substance misuse conditions and or complex behavioral health cases can really get some comprehensive case management would be great. Thank you so much. I appreciate your time.
Thank you, Valerie. And not to open up a dialogue for public comment, but if you could just, for the record, expand on the acronyms that you used so that we make sure it's clear for anyone watching and for our minutes.
Absolutely. So for MDT, that is multidisciplinary team, usually a group of multiple sectors, including law enforcement, healthcare, case managers, and behavioral health providers that may be working with an individual. And that would be outside of an AOT or ACT team, which would be under one specific organization, which is not really feasible for most of our communities. Another acronym I used was ADSD, which is Aging Aging and Disability Services, or Nevada's Adult Protection Services Agency. I believe that is it on the acronyms.
Those were the two that I wrote down. Thank you, Valerie. Appreciate that. And do we have anyone else here for public comment? I don't see any hands
I don't
raised.
see
Anyone on the phone?
We have someone connecting to, I think someone just joined us, but I don't see any other hands raised. Bethany, you are not on mute, so I'm not sure if that is an indication you would like to give public comment or not. If you are not choosing to give public comment, if you wouldn't mind muting your phone up.
No public comment. Sorry about that.
Thank you.
Okay, seeing no more public comment, I'd like to now move on to agenda item number 3, reviewing and approving our August 23rd minutes. So I'd like to open it up to any questions or comments or revisions. Seeing no hands raised and not hearing anyone, you're also always welcome to unmute yourself if I miss your hand raised. But seeing no comments, do I have a motion to approve?
This is Terry Kearns for the record. I move to approve the minutes from the August 23rd meeting.
And Stephanie Woodard for the record, I second.
Okay, wonderful. We've got Terry Kearns motioning to approve and Dr. Woodard seconding that motion. All in favor, please say aye or raise your hand.
Aye.
Aye.
Any opposed? Say nay. Okay, we have unanimous approval of the minutes. So now we get to move on to the bulk of our time here today. And this has been a long-awaited meeting. We've had presentations from subject matter experts over the past few months. We've been soliciting recommendations from the members of this subcommittee to address our recommendations that will go into our final report that we will finalize in December after the committee as a whole, if you will. The SURG committee will have a chance to weigh in. And then that report will then go to our legislature, governor, the Department of Health and Human Services to make our best recommendations for policy changes, for budgetary requests, and for use of the settlement dollars, along with any other programs or strategies to address substance use in our state. And so I just want to, before we dive in, thank all the members, because this is incredibly important, as we know, work, but also incredibly complex. And I have really appreciated seeing the input and the recommendations, the thought behind them. And I look forward to the discussion as we get to a place where we can put forward the recommendations from this subcommittee for the whole SURG committee to consider in our October meeting. I also want to remind you, if you weren't here last meeting, that I announced that my term will be ending in November, which means that my place on this committee will also be ending. As I promised to many of you, even as we were starting this meeting, I am not going anywhere, and I certainly am not going to stop caring very much about this issue and being engaged. But my role will be more as a member of the public and as a concerned citizen. So I'm going to be passing the baton for this subcommittee chair position to Terry Kearns, who will be chairing this subcommittee from here on out, and then continuing to represent our voice in the SURG committee as a whole. So with that, I'm going to pass the baton, pass the gavel to your new chair, Terry Kearns, who will walk us through this process of going through these recommendations with the hope that we can get to anywhere from 5 to 10 recommendations out of this subcommittee that we will then put forward to the whole search committee to vote on and put into our final report. So baton passed. Chair, the gavel is yours.
Thank you. I appreciate that. And thank you so much for everything that you have done for this committee and for the SURG at large. So we're going to talk about finalizing our recommendations. And I just want to remind those who were here for the last meeting and those who weren't, just to let you know that we had previously prioritized our recommendations. And after we did that initial prioritization, we had additional recommendations that had come in. So we wanted to ensure that those recommendations also were considered. And we also talked about if there was any way we could combine some of the prior recommendations. So all of that was done. And then a poll was done to reprioritize the recommendations. And I would hand it off to Crystal to see if there's anything you want to add and discuss on that whole process.
That's been the process. So as Dr. Kern stated, we received recommendations all throughout. We received them from our committee members as well as from presentations. We had a total of 48 recommendations. The subcommittee prioritized and ranked those, and we have the information on all of that available. And from that ranking, then we did a second round of ranking with our new priorities. So we ranked in July and we ranked again in September. So what you're going to see on the following slides represents the cold down version of those recommendations. Because when we ranked again in September, we only ranked recommendations that had previously been ranked and new recommendations. So I just wanted to acknowledge how we got from 48 to what you're going to see on the slides presented today.
Thanks for that, Crystal. I appreciate it. And just to let everyone know, the results of the second round of rankings are presented on the following slides in their order of priority. And the recommendations were categorized, and they may warrant some additional consolidation, as there were 7 categories that emerged within these recommendations. So we'll start with the new recommendations and the prioritization. You can see first that these were new recommendations that came into us in September to increase and expand maternal, infant, early childhood home visiting programs within the state of Nevada. Also support funding decisions that increase funds to evidence-based programs that strengthen and educate families. And you can see we had a recommendation in our last meeting to combine these 2 recommendations into one. There was an increase of state funding for substance use treatment facility beds on a grant basis. And this would aid in research regarding the impact of having treatment available on the economy. And then funding for an API for the ODMAP system. This was resubmitted as a recommendation. We had taken it off and resubmitted it because the funding that we thought was going to be in place was not. We may have an update on this in terms of getting some temporary funding from it through DHHS for a 2-year period. So this one can likely be put on the back burner for now until we do have 2 years to address this further. And what I would like to do is see if there's any comments on these additional recommendations, and those that provided these recommendations, if you have anything you would like to add to this.
Sarah Kearns, Shayla Holmes has her hand raised.
Shayla, please go ahead.
I just wanted to comment that I did recommend the expansion of the maternal, infant, early childhood home visiting and also the evidence-based programs for families. And then I also made the recommendation to combine them, given that I think lifespan or the whole grouping of youth in regards to our last presentation or our last meeting where we discussed that we had no recommendations for youth and how we were going to address the issues that were brought up regarding youth, and that as a state we do have some programming that exists, and I think it can be expanded, and I think there can definitely be more funding put into those programs that have those outcomes in order to also focus on this effort. So I just wanted to throw that out there as far as where that thought process came from for those two items.
Thank you for expanding on that, Shayla. I just wanted to ask a question that came to my mind was, do you think these should reside in the response, or would they fit better in any of the other subcommittees such as treatment and recovery or prevention and harm reduction?
You know, that is a difficult distinction to make, and something that I continue to struggle with in regards to community response. I believe it is community agencies, nonprofits, and or government entities that implement these programs. The Maternal Infant Early Childhood Home Visiting Program is a community response to a variety of different issues that impact families with youth. It could be prevention, but the way that a lot of these families are, or a lot of these programs are set up, some are prevention, some are intervention, but I do think it is a response from the community in regards to how we can respond to the opioid misuse disorder in our community. So it could fit in either depending on the programming, because there are different ones that target different areas.
Thank you for that explanation. And one thing I would highlight is I think that we likely will come up with recommendations that could go across multiple or all of the subcommittees. So that will be something that we'll talk about further, I think, in our upcoming October meeting as well. Can we go to the next slide?
Dr. Kearns, this is
Yeah.
Stephanie Woodard. Could I just ask one clarifying question before we move on?
Certainly.
So Shayla, thank you for submitting the recommendations, and I agree with you. There's quite a bit of space that I think we can optimize the MIG-V programs and other home visiting programs to meet the needs of families at risk or families who are impacted by substance use. You had said something in your last comment around opioid funding, and so I'm just wondering if you could clarify, is this a recommendation that you would like to see supported through Fund for Resilient Nevada, or are there other funding streams that you think also need to be included in this consideration?
My thought process for this specific recommendation was Funds for Resilient Nevada. I do know there are other funding streams potentially out there that do fund some of these programs as well. But I think they don't target the substance use issue specifically, and they're limited because of the funding streams. So I think by increasing the funding available to those programs utilizing Resilient Nevada funds, we could see a bigger scope of those programs and be able to do a better job at responding to the substance misuse.
Okay, thank you for that. Stephanie Woodard for the record. I know that home visiting programs and other programs for families that are either impacted by substance use or at risk for substance use had already been identified as recommendations through the needs assessment. And so I just wanted to make sure that we were aware that those recommendations have already been put forward.
That's a good discussion. Thank you for that. Are there any other comments or questions related to these recommendations? Okay, hearing none, we'll move on to the next for the prioritization of the recommendations. As you can see, the top priority based on the points in the ranking was the surveillance and data. And again, I would add that much of this could go across multiple subcommittees. When we looked at this, you can see there's that general category of surveillance and data. And the first point is to establish a statewide and regional overdose fatality review committees that would effectively identify system gaps and innovative community-specific overdose prevention and intervention strategies. Also, as part of that was the request for funding for an independent medical examiner for reports that verify the specific cause of death in overdose cases where the source of the drug supply has been identified and can be prosecuted. The next point is standardized data sharing agreements between public safety and public health that support data sharing and allow for the redisclosure to inform risk messaging. Then that final one, funding for the automated program interface, the API for the overdose mapping application system, which we had discussed in the previous slide. I had questions. I don't know if anyone else does. First, I'll open it up to see if anyone has comments or questions on these recommendations under the general category of surveillance and data. Dr. Woodard, I see your hand up. Please go ahead.
Thank you, Chair. Stephanie Woodard for the record. I think one of the things that I struggled with just globally when going back through these priorities is sometimes the lack of specificity. While the activity seems like it could be specific, it's unclear if it is a request for a recommendation for legislation or policy or funding or sometimes both. And so as I provided feedback on the recommendations to the group, I tried to really highlight some of those core questions that I had, which I think do need to be answered in order for this committee to make some final determinations on what recommendations we want to bring forward to the larger SURG group, only because I anticipate that those conversations would ensue in that venue as well. So as it relates to the first bullet point, one of the questions that we have had is, would a statutory bill draft need to be considered in order to establish overdose fatality reviews? And I believe that we have consistently concluded that having legislation to establish overdose fatality review committees at a statewide level would be needed. And that to establish them at a local level may actually be under the authority of local entities and agencies, including potentially health districts. So I would like to see us refine this recommendation a bit further to highlight the need for a potential BDR to establish overdose fatality reviews so that we could do this at a statewide level. And then certainly having the legislation as one piece, but then also ensuring that we are looking at sustainable funding to also enable these groups to be able to assemble and do the work that they do is also very important. There's lots of lessons learned by other overdose fatality review or by fatality review committees that we already have, that it does take some administrative support as well as some additional funding to make sure that we can get all of the committee members in the same room to have these conversations, and potentially some additional support for data collection and analysis. So my recommendation on the recommendation would be that we would further refine it and identify that we are looking to establish a BDR to develop the overdose fatality review committee in statute, and to recommend an allocation for funding to support those activities.
Thank you for that. And I guess my question is, do you envision, or do the members of the committee envision this being at the statewide level? Because I think there is some work being done also at the local level. And would that need to be called out within the establishment of the BDR?
So Stephanie Woodard for the record, I do think it's an important point of distinction. I do not believe that we need a law to enable regions to be able to establish their local community-based overdose fatality review committees. There already is, in many cases, free exchange of information between the health authorities and the medical examiners or the coroner's office. I could be wrong, and please, Shayla, you probably would know better than anyone else on this call if perhaps that isn't the case, and we would need statutory authority to establish overdose fatality review committees at a local level. But I do think we do need that that authority in order to be able to establish them at a statewide level.
This is Shayla Holmes for the record. I would think, you know, every county interprets things differently, unfortunately, but given, you know, our state structure, I think the counties would need expressed authority to be able to do that, unless, of course, the health district legislation moves forward or health districts are created, at which point then I think that could fall under that authority, but not all counties are at that point. So it's one of those things where I think it is really dependent as far as where the forward movement of those health districts and the health authorities go as a region, which right now is only happening for, I think, Central Nevada and the counties involved with that health district. So I think I mean, expressed authority, I believe, would help with creating that conversation at a county level, but that's just what I believe would be the right process there. I could be totally wrong.
So Chair Stephanie Woodard, for the record, with that, I think perhaps we don't limit it in the recommendation to only suggest recommending BDR to establish the overdose fatality review committees at a state level, but that for now we also include expressed authority in regional overdose fatality review committees until it can be determined otherwise that they don't need to be included.
Thank you for the comments and the clarifications. So maybe something more to the effect of establish a BDR to implement a statewide overdose fatality review and to provide the counties with the express authority for regional overdose fatality reviews, and then also recommend funding for that. Is that close?
Stephanie Woodard, for the record, I would say yes, but I would also defer to our legislative representative on the call for her input on that recommendation.
Thank you for that. I was trying to find my hand button to raise my hand, so that was a nice pivot. So I think that putting it in the recommendation, state and local, if that's what our working group wants to put forward, our committee wants to put forward, certainly handles both, but it brings to mind some questions for me. Who would make up this committee? And I know that that's the kind of questions, if we go down the road of a BDR, is this housed in health and human services? Is this housed in law enforcement? Is this a multidisciplinary team, right, where you have appointees? Who does the appointees? There's a lot of questions that start to snowball for me in terms of who makes up the overdose fatality review committee. And then leading into that second sub point, how does maybe an independent medical examiner fit into this, or by nature of the word independent, should that person be outside if we decide to adopt that? So I have some questions from a legislative standpoint as to how we can word this in the best way to not be so over prescriptive with the recommendation that we're writing legislation here. We don't want to be so detailed that we're writing a BDR, but also to Dr. Woodard's point, we want to give enough direction that a chair of a committee, let's say, could look at it and say, well, this is useful. Now we can take action. It's a little bit further along the road to take an action step to see it successfully and move forward. So first question, who makes up the overdose fatality review committee at the statewide level, and who would make that up at the local level? just so I have a better understanding.
Yeah, and I think that is going to be really dependent on each jurisdiction. I know I've been involved with some community practice concerning overdose fatality reviews and technical support from the at the federal level. And it really depends on each jurisdiction as to who would be involved. They give categories. There's a whole toolkit that they have and they've put out that we could definitely rely on for their guidance. And it's kind of best practices, what's worked, what they've seen throughout the country, both for a statewide and then at the local level as well. The other thing, and Christine Payson, if you're on, I think the recommendation for the independent medical examiner was your recommendation. Do you have any further information you could provide on that?
Just that the number of cases per year seem to be pretty minimum at this point. So it's not going to be something that we would be looking to. Yeah, that's my dog. Sorry. He's been quiet all day, just when I talk. Okay. So it wouldn't be a permanent position that's all that person does. It would just be an additional duty as needed when the cases have enough merit.
Christine, do you see that position residing in either like Washoe County or at Clark County, or how do you have any recommendations on that?
Just by the number of cases I've seen so far, it looks like more of them are occurring in Clark County, and that's just because of the greater population, I would assume. But I don't know that it's not. Could that be something that the person could move about to do since the cases are few? That I don't know how that would work.
I'm not sure of that either. That's something we would have to probably look into. Do any of the other committee members have any thoughts on that independent medical examiner?
I noticed Dr. Woodard had her hand raised.
Thank you, Stephanie Woodard, for the record. My hand was raised more on the overdose fatality review committee recommendation. And I just wanted to reiterate that there has been quite a bit of work done on this nationally. So there is a toolkit and there are recommendations on what roles should be represented within an overdose fatality review committee. So for the purposes of our recommendation, I would like to suggest amending this if we do decide to go forward with it as a priority recommendation, that it would be in accordance with established best practices. And then we could certainly review those best practices to aid in the development of a BDR concept.
Thank you. I think that's a good idea. And I would add too, I know we have the standardized data sharing agreements between public safety and public health to support data sharing. That is also a component that's in that toolkit for best practices. So that is something to Dr. Woodard's suggestion that we could also include within that, is looking at those best practices for data sharing. The automated program interface, I think really that can fall off of this for now, because as I mentioned earlier, we do have a funding stream for 2 years. So I don't think we need that. I don't know specifically, I don't remember in the toolkit, I don't think there was anything on the independent medical examiner. So maybe we can dig a little deeper and see if any other states are using this and find out what the best practices are. Do you know, Christine, is this being used anywhere else?
I do not know, but I know that the number of states that are actually able to go forward with these prosecutions seem to be pretty small. So there's not going to be a whole lot of places we can draw from, but I'll do a little homework and see what I can find out.
Great, thank you. So Crystal, have you been kind of formatting any wordsmithing on that? Something establish a BDR for a statewide and local overdose fatality review committees, utilizing best practices, and provide the express authority to the counties for regional overdose fatality review, something like that. Do you have anything, Crystal?
I do. I think I'll have to figure out a way to get all of it in there, but I can read back what I have. Support legislation to establish a statewide and regional overdose fatality review, to support overdose fatality review committees, and recommend an allocation of funding to support the OFR to effectively identify system gaps and innovative community-specific overdose prevention and intervention strategies in accordance with established best practices. And then we could cite the OFR best practices within our recommendation.
Thank you for that. I thought that sounded good. Any comments from any of the committee members on what Christine just read us? I don't see any comments. Okay, I think we're good on this one. So that should be able to take us to the next recommendation. So the second prioritized recommendation going through our prioritized list, as you can see, is for criminal and civil penalties. The first bullet point is to amend NRS to assign lengthier prison sentences to dealers that sell fentanyl with or without knowledge in the state of Nevada. If a dealer's drug sales are directly correlated to an overdose event, fatal or non-fatal, additional charges should be applied. Trafficking weights of fentanyl should also be lowered to previous law standards. And then you can see the suggested revisions based on the quantities of the fentanyl that is trafficked. And Christine, I believe this one was yours. Do you have, I know there was discussion about amending some of the language in your prior presentation.
There has been discussion. I've talked to the folks in intergovernmental affairs, at least with Las Vegas Metro. And quite honestly, I don't know that anyone's come to an agreement on what that verbiage should look like.
Okay, does anyone else have any thoughts or recommendations for this particular recommendation?
Chair, we could ask Christine, there was a chart that from a previous presentation that was really the motivating force behind wanting to revise these sentences and looking at the weights and the impact that that could have on the number of fatalities. And I'm just wondering if anyone has that chart, or if Christine has that, to be able to just bring us back into the importance of why this landed as one of our #1 recommendations for most, if not all, members.
Right, and it just showed the different, the former trafficking levels and the number of people that could kill compared to the current standards, which is exponentially more. I will look through my files while we're in the middle of this meeting. If I can find that, I'll get it to Crystal and hopefully she can put that back up.
Thank you both for that. And I had a question too, looking at this and then looking at some of our other recommendations for looking at the criminal and civil penalties. I didn't know if this could be added to those, and those will come up in just a minute, where we can talk about that in order to see if there's any thoughts on like an omnibus bill. I have seen some other states that have done that. Colorado was one, for example, and it included language on changing the charges based on trafficking weights. It also had discussion on the Good Samaritan law and really targeting more for the trafficking as opposed to an individual who's trying to help someone, and some other ones which we can provide that to all the members if they would like to see it as well, as a way to either, and we can talk about this, do we want to keep this as a separate one and look at some of the other recommendations separately? If any of the committee members have any thoughts on that.
Derek, I'll jump in here. So I do think that it's because it's been such a priority for so many of the members. I do think having it stand on its own is warranted, so that it doesn't just get line item edited out of a omnibus recommendation. And it will be up to the legislature to decide if they want to put this into another larger bill or to make it a single item bill. But I think that simplifying this recommendation so that it's as broad and straightforward as possible will, I think, be embraced by the largest audience. And so I like the suggested revision that says revise penalties based on the quantity of fentanyl that is trafficked, and the reference to the NRS. And then that way it's a very clear, strong recommendation that hopefully everyone, not just in this subcommittee, but when we have this discussion among the larger SURG committee, could feel comfortable getting behind. And then when we get to the legislative process, we can pull those numbers, compare them to previous legal standards, and then address some of the more specific details, like whether or not it's correlated to an overdose event. I think that it's much stronger to leave it at that revised language, and then work with the BDR sponsor on some of those specific details and elicit as much support as possible. But I think we're setting ourselves up for the highest likelihood of success behind this recommendation, not just in this committee, but also with the SURG committee as a whole, to keep it with the revised language.
Thank you for those comments. I think that's really an important point that you make in letting this stand on its own. And I do think maybe this is what Christine had provided before, that the prior legislation was less than 4 grams is considered low-level trafficking, and less than 14 grams, which is deferral, would be the potential to kill 6,995 people. The prior legislation then had 4 to 28 grams as mid-level trafficking, and greater than 14 grams, less than 28, 1 to 4 years with the potential to kill 13,995 people. And then the prior law was 28 grams or more would be high-level trafficking. And Christine had provided greater than 28 grams or less than 42 grams, 1 to 10 years, potential to kill 20,995 people. And then finally, greater than 42 grams, but less than 100, 2 to 15 years with the potential to kill 49,995. Does that sound like what you had presented to us, Christine?
It sounds like, and I was trying to pull it up at the same time, the slide that I did in my actual presentation. And then a couple of weeks ago, you and I exchanged an email where I had a little more updated info. And I'm going to try and put that in the chat. Is that okay if I put that in the chat and then Crystal can read it? Or do you just need me to read what I think the new numbers are?
Crystal, which do you prefer?
I believe that's okay for me to put in the chat, but the other option I have is to just create a really quick slide with the information Christine shared in her email. So as long as I don't hear anything from from Joel that that would not be okay to do, I'm gonna be working on that very quickly.
Okay, and I'm going to just put what I believe to be our latest conversation in the chat, so we'll make sure we're talking about the same numbers. So is that all right?
What was that question again?
Joel, the question was, we're trying to update some current information that would be included for this NRS recommendation change. So the question was, can we A, amend this and then put the slide up, and B, can Christine provide that to Crystal in the comments, in the chat?
Right now, as we sit here,
Correct.
I believe that should be okay since we're doing it open in front of the public and that's for public consumption anyway.
Okay, thank you. So
I say
Christina,
go
Yeah, and I can see that it's the same as what I've just pasted in there into the chat. So that's our latest info. And if that's the same as what you read, Terry, I apologize. I was trying to find it and listen at the same time.
no, that's okay, no problem. So Crystal has put together what we were just discussing, what the prior law was and what the recommendations. Do I hear any comments from the committee on this change, amended language?
Chair. If I
Please,
may,
Dr.
Stephanie
Woodard.
Woodard. Thank you. Stephanie Woodard for the record. One question that I had, and certainly am not attempting to complicate things here, but what we are seeing is the proliferation of additional synthetic opioids that are hitting the illicit drug market. My concern here is if we leave it singularly to fentanyl, if we may not have to have the same discussion in another 2 years because other analogs have similarly been developed with similar levels of potency. So I'm just wondering if we may want to take that into consideration when proposing this recommendation. I don't necessarily have an elegant solution to propose, but did want to bring that concern forward.
Thank you. I think that's a valid concern. I know in some of the other legislation that I have seen, it was fentanyl and analogs. Christine, do you have any thoughts on that?
Yeah, I think that's a great idea to include any additional analogs, or if we can word it that way, emerging, novel substances, because we know they're creating new ones every day. So if we can have some kind of broad language that covers what we have and what we know is coming, that would be ideal.
And Stephanie Woodard, again, for the record, if I may, Chair, I think the issue that we're trying to address here is the significant level of potency that fentanyl and potentially other synthetic opioids have, which render some of the existing weights and penalties in existing statutes really not applicable because of the comparison to the implications for even just low levels of these drugs to be present. And so I don't know exactly how we can address that, but I do think really what we're trying to get to is that for fentanyl and other similar drugs with similar levels of potency, or I'm sure there's some better terminology there, that those are considered. Because what we don't want to do is broaden this so much that potentially a drug that could otherwise be covered by existing statute appropriately would then be pulled into these weights and penalties. But we do want to make sure that we also have some flexibility as new drugs really enter the illicit drug market, that when they are similar in potency, they would be included with these weights and penalties.
Thank you, Dr. Woodard. So perhaps something revised penalties based on the quantity of fentanyl, analogs, or other synthetic drugs of high potency that are trafficked, and then include the NRS that we had from the previous slide.
So Stephanie Woodard, for the record, I think that gets us most of the way there. Obviously, there's going to need to be some, I think, cleaning up of that language to make it more accurate. And certainly our partners at Board of Pharmacy and others could likely assist us in creating more specific language. But I think that gets us most of the way there.
Christine, what do you think of that suggested revision?
Oh, okay. I swear the second I found the unmute button while I struggled for it, you know what, apologies. I think that's excellent. I think that's going to get us in the right direction.
Thank you, Christine. And we'll note that your dog agrees.
Am I the only one that had a heart attack when that happened?
You have to note for the record that my Boston Terrier heard your dog and burst into my office, very curious to know what's happening.
Thanks for the a little levity in the meeting. So I think we're good on then some suggested language, and we can reach out as suggested by Dr. Woodard to the Board of Pharmacy and see if there's any other perhaps language from any other model legislation that we can see. Can we go to the next slide? So the next, or the third prioritization, had to do with crisis response systems. And as you can see, the first bullet point is implement a comprehensive integrated crisis response system to coordinate public health and law enforcement to reduce harms through deflection, diversion, and medically assisted treatment. And a point under that, crisis outreach response teams, similar to or enhancing most ACT lead teams to respond to any suspected overdose and offer follow-up support, referrals, and services to the individual and loved ones for up to 45 days after the overdose. Teams to be dispatched to anyone being released from an institutional setting who is being discharged post-overdose or suspected overdose. And then the next bullet point is funding for additional police overdose response teams to respond to and investigate overdose related crimes. I know I had some questions on this, but I'll open it up to the committee members for comments or questions first. Okay, hearing none, I guess my first question was, does somebody have a comment?
Dr. Woodard raised her hand.
Dr. Woodard, please.
Thank you, Chair. I actually had some questions around the second bullet point. I was unclear as to what was actually being requested in that recommendation. So this was, let me just pull it back up. I was asking, is this a request for an allocation of funding or for Medicaid to cover this as a service benefit? Or is this a request for a BDR for legislation to define the service, or any combination of the three? I was looking for some clarity there.
Okay, and I don't remember whose recommendation this was, Crystal, who?
I believe it was Shayla's, and she actually has her hand raised.
Okay, Shayla, please go ahead.
Shayla Holmes, for the record. I think I was a person who recommended something along this, and I think it's been perhaps condensed with some other stuff as well. But Dr. Woodard, in response to your question, I think it is all three. I think it's funding and perhaps legislation to allow it to be a permanent response. I don't remember what the third option was. Medicaid billing. I think Medicaid right now currently has crisis response as a part of that, but I'm not sure how that works with the substance use response. I know under provider type 14, that would be eligible under behavioral health, but in regards to how that works with substance use, I'm not too sure under provider type 17 what that looks like. So perhaps it's expanding into both Medicaid types. I'm not sure. I'm more familiar with 14 than I am 17.
So Chair, this is Stephanie, if I can add.
Please go ahead.
Stephanie Woodard for the record. So thank you, Shayla, for that. We do have a CMS Mobile Crisis Planning Grant currently, and we are looking to establish what are called designated mobile crisis teams. And those crisis teams can be deployed for any crisis. And there are some strict criteria around those. So the issue of like up to 45 days, I think would be certainly a challenge to make that fit into the current Medicaid structure. In addition to that, 17215s do provider type 17215s, also known as the substance abuse agency model. Providers under Medicaid do have the ability to bill for crisis intervention. And so I think I understand where this is going. I do think that we have some activities that are currently already underway that may get us at least part of the way there for this recommendation.
Thank you, Dr. Woodard. And that was kind of one of my questions. I wondered, was there a difference in role and function of the crisis outreach teams under what you talked about with the mobile or the CMS mobile planning grant with the 988 responding to all crisis? And then also to go further, is there a difference between these crisis outreach response teams and the police overdose response teams? And are the police overdose response teams being recommended statewide or for specific jurisdictions? Shayla, I see your hand up. Please go ahead.
Shayla Holmes for the record. I, when reading these two recommendations, see them as two very differently focused responses, in that if we blend the investigation piece with the outreach as far as referral and connection to services piece, I feel like we might be creating mistrust for the population needing that assistance. And so I saw them as two very separate recommendations. I didn't make the overdose response teams for investigation. I think that came from Ms. Payson, but I did just want to also touch on the institutional cross sector there. I think it's really important, even, and perhaps crisis response is not the appropriate term for the recommendation when it comes to 988 and the other crisis response teams that are being created for individuals calling in an immediate crisis, and that there's a mechanism or a scope created to allow for individuals being released from those institutional settings to have that in-home response and follow-up care that's just automatically dispatched from, upon release to ensure that long-term connection. I don't know if there's other teams in existence where that scope can be expanded, but I definitely think that's the critical aspect of this recommendation from my perspective, is that continued follow-up post-release from whichever setting's coming from, not necessarily that crisis in the moment response of overdose where EMS is perhaps being dispatched or naloxone being utilized or something to that degree.
Thank you for that, Shayla. That really helps me to understand the recommendation. I saw Christine Payson also had her hand up.
Hi, thanks. Yeah, and I agree with her that those are very different categories, but the LEAD program was mentioned, and not to redo my presentation, but just a real quick recap. They changed the acronym, so now it's LEMA, or Law Enforcement Intervention for Mental Health and Addiction. So this is the overdose response team. That's a very different animal. We're looking to get the source of supply. But as far as crisis outreach, the Lima team is a 9 to 12 month pre-booking diversion program to address low-level drug crimes. And there's also a homeless outreach team. Now, these are Las Vegas Metro teams, but to your question, some version of these would be very beneficial statewide for any department to be able to do the homeless outreach. And they have resources and knowledge that the average patrol officer is not going to know. And they're going to be connecting people resources. And there's also the CI team or crisis intervention team that have special training to provide direction and guidance in events where people are in crisis, showing signs of and Dr. Woodard, I know you told me that it was no longer excited delirium, but I can't remember the new term, but also people with mental illness or developmental disability. So there are other teams that are law enforcement related, but not the strict focus of the overdose response team looking for that source of supply that caused death or near death. I hope that made a little bit of sense.
That did. Thank you for that clarification. Dr. Woodard, I see your hand up.
Thank you, Chair. So I appreciate Shayla clarifying the goal of this recommendation and would say that part of this may also relate to the emergency department bridge programming that we are currently working with the Nevada Hospital Association on to ensure that individuals who are ready, willing, and able to engage in either recovery supports and or formal treatment have the opportunity for induction in emergency room settings or in hospital settings, and then have the linkage and referral and follow-up to care that I think was also discussed. So I'm wondering if we might be able to consolidate this recommendation a little bit more so that there's less specificity in the language. I think that's where I'm running into some issues is things like 45 days and that the teams have to be dispatched may be making this perhaps too specific and may not allow us to really leverage some of the existing programs and funding that we already currently have specifically to address the needs for individuals following a non-fatal overdose.
Does anyone have any recommendation instead of integrated crisis response, another term that we should be using? Because I think there is some confusion with the, people who are in immediate crisis that need systems and support versus what we've just been talking about.
Perhaps the crisis piece could be removed and it can be just outreach response. Not sure if that's getting us quite where we need to be, but I think we can remove the term crisis, which opens up a bit.
Yeah, that's a good suggestion. I do like that. So something perhaps to the effect of leverage existing programs and funding to develop outreach response teams to respond to any suspected overdose and offer follow-up support, referrals, and services to the individual and loved ones following an overdose. Teams to be deployed to anyone being released from an institutional setting who is being discharged post-overdose or suspected overdose. Thoughts on that language?
Chair, Stephanie Woodard, for the record, the only other suggested edit that I'd like to put forward is maybe doing something with the word team. Team to me is indicating that it's more than one person. And I think we may, what we've learned with mobile crisis especially is that in some situations it really is a person, not necessarily a team. And so I think the goal here is to ensure that we've got an opportunity to offer support and intervention for individuals with a non-fatal overdose or suspected overdose, but I asked Shayla if that would complicate the recommendation that she has put forward.
Might I suggest the
This is
word
Shayla
personnel?
Holmes for the
Go ahead, Joel.
I'm sorry, I just thought the word personnel might be open enough to include single individuals as well as groups.
That's why I wonder personnel or provider. Shayla, please go ahead.
Oh, sorry, I was having some lag, I think. Shayla Holmes for the record, I would agree with either of those, either individual or provider. I think provider is probably more broad, but I think both of those keep with the spirit of the focus of this recommendation. And as it's coming back to me, I think the pieces and quotes came from a direct research article where this, I think, was being implemented in Arizona, and I think this came from a research article just validating the results of what they were doing. But I think as far as what we have going and what we're working on here in Nevada, I think that those edits and creating it more broadly works perfectly.
Okay, so if we change that teams to provider or providers, that would address your concerns, Dr. Woodard?
Yes, thank you, Chair.
So then my question then becomes for the funding for additional police overdose response teams to respond to and investigate, that's a separate recommendation from what we're calling the outreach response teams. Christine, do you want to add anything, please?
Thanks, Christine Payson for the record. Yeah, that would be a second recommendation. And my question is, if we use personnel, would that still encompass the teams like the law enforcement diversion and the homeless outreach and the crisis intervention teams? Would that still be considered part of the personnel and be possible to receive some of the funding for additional teams? Excuse me, additional teams for that aspect of law enforcement, with the overdose response team being a separate and very specific recommendation.
I would see it as including those teams because it's to reduce the harms through deflection, diversion, and offering a medication assisted treatment. So I would think it would. Any thoughts from any of the other committee members?
Stephanie Woodard for the record. I think that's part of the goal in broadening the language, is that we can potentially move forward with a recommendation and not get locked into needing it to be a team or an already existing kind of team like the Lima or ACT or MOST or FASTER or something else, but keeping it nice and broad so that we could utilize it, because we don't have MOST teams or ACT teams or Lima teams in every community. And so I think that we want to make sure that we have the ability to apply the recommendation to all communities for statewideness.
Thank you for those comments. Any other comments on this recommendation from the committee members before we move on to the funding for additional police overdose response teams? Okay, I don't see any. So then we would need to look at language for funding for additional police overdose response teams to respond to and investigate overdose related crimes. And again, as we discussed, I think these don't exist throughout the state. So would our goal, I think from what you said, Christine, would be to have them statewide. My question would be is, do all of our jurisdictions, all of our counties and law enforcement have the capacity for personnel for these teams?
Well, I would guess that their answer would be is as long as somebody funds it, then yes, we have the capacity.
Yeah.
Chair,
Go ahead, please.
I think you actually do bring up a valid point, because that is a conversation that we have often in our budget committees is, even if we do fund it, do we have the workforce? And so, and I know that we do have recruiting challenges in law enforcement, having sat in those hearings from our various agencies. So I do think it is a little bit of a chicken and an egg. We both need the funding, but we also both need the trained professionals in the workforce to be able to fill those. So just a side note there.
And I guess a thought for me would be, would there be any consideration to looking at our areas that we see these crimes the most? So obviously, Christine, you mentioned Clark County, perhaps Washoe, and then I know there will be other communities, but I don't know what those would be. So we would probably need to get additional data to support where these teams should maybe start being implemented in.
Shayla has her
Chair,
hand
this is
raised up.
Shayla Holmes for the record. If I may, just in conversation with our local sheriff's department, perhaps this could be broadened similarly to the other one, where funding for additional police response to and investigate overdose-related crimes and removing that team component. So in Lyon County, which we are, the largest rural county by population, we have investigative teams, but they lack the funding to be able to do the necessary testing on all of the potential fentanyl pills. They might not be fentanyl. They don't test all pills that they recover due to limited funding resources. So there are places where they might be able to increase their investigation ability if they had funding to do more testing, kind of that chicken and that egg piece. So I think perhaps this recommendation could be broadened to allow for funding to be utilized as each jurisdiction has that need, versus creating a mandated team on jurisdictions that might not have that need or have that capacity.
Thank you for that, Shayla. I also saw Christine Patient's hand up and Assemblywoman Tolles. So Christine and then Assemblywoman Tolles.
That was me forgetting to take my hand down for my last one. Thanks.
Thank you.
So in light of the conversation around broadening, I'm curious how this might fall in line with the independent medical examiner. And if perhaps this is an opportunity to take a look at how we could combine it with that recommendation, so that you have an independent medical examiner who is, investigating overdose cases to help identify the drug supply and source for the purpose of prosecution. And it also just seems to resonate with additional police overdose response to investigate overdose related crimes. So maybe they are totally separate, because one perhaps falls into public health, the other into law enforcement, or perhaps they're combined. But I want to just point out that what we're trying to accomplish here are the avenues by which we can help investigate, so we can cut off supply. And so we can go after those who are, I believe it was Christine Payson in our very first meeting who used the word poison, and it, stuck with me, right? We want to be able to respond, we want to be able to treat, but we also want to be able to stop these things from coming in, and that's where the investigation piece comes in. And so I just see these two parallel tracks, and I wonder if they should be combined or if they need to be kept separate as we're having this discussion.
I think that's a great recommendation. Something maybe perhaps fund personnel and resources to investigate and prosecute related crimes, including an independent medical examiner that reports that specify the cause of death in overdose cases where the source of the drug supply has been identified and can be prosecuted. Christine.
I would solicit the input of Christine, since those were primary points of interest for her as a committee member.
Yeah, I think they can be combined. I mean, at the end of the day, we want to hold the people responsible. So I think that's reasonable to combine them.
Thank you, Christine. Any other thoughts from committee members? And maybe we need to wordsmith it a little more, but something similar to what I just said, as would be in our separate recommendation, taking it out of that outreach response system. Okay, that sounds good. I think unless there's other comments on these two, we can move on to the next.
Chair, Stephanie Woodard for the record, just a point of clarification on process, if I may.
Please go ahead.
Because on the previous slide, there was such depth of conversation around changing some of the language. Will we have an opportunity to review new language on these recommendations prior to putting our votes forward for what we would like to see prioritized?
Yeah, I think we're going to have to do that because some of them have been somewhat significant changes. So to that point, I think we'll have to put everything together as we revised it and then push it out to the committee members. And it may require having to do another poll to prioritize, seeing how we separated some out and those. Thoughts on that process? And Joel, would that be good for us as a committee to be able to do that before taking our recommendations to the larger surge?
One more time, I kind of drifted out on you there.
I think the question was on the process, seeing how we're changing some of our recommendations by combining or pulling out. So as a process for this committee, can we then, once we collate everything that has come out of the meeting, push that back out to the members for their consideration on looking at the new verbiage and then prioritizing?
That's where it gets tricky. I don't think pushing it out to the members in private or in a group email would be kosher with the OML. It would have to be done either during a meeting or in the supplemental materials for the next meeting so that it's all public matter and public knowledge and done in front of the public.
Okay, and that's exactly what we did with this one is the committee members reprioritized them as we discussed in the beginning when we had those new recommendations. And now we're discussing them as part of the meeting, and that's all provided as additional resources.
Yeah, so let's keep that process and do it again, not take a shortcut.
Assemblywoman
I would
Toles.
just, sorry, I've been creating revised recommendations, and hopefully if we can get through the next few segments, we can at least share those on the screen. I don't know that we would get a chance to wordsmith based on the timing of this meeting, but we will hopefully be able to share those at the end of this meeting to get us at least started on that process.
As long as it's all in front of the public and nothing's disseminated to the group members that's not in front of the public, you're good to go.
So Chair, my recommendation would be that we have two potential directions we could take. One, we can finish the discussion of the last few recommendations, and then have the notes with the revisions that we've conceptually discussed up on the screen, and then we can take a vote based on those revisions, with the disclaimer that we, when we present this in October, we may have some additional revisions in that committee meeting of the whole and reserve the right to change our vote. That's how we handle it through the legislative process. It's analogous to the work session, where oftentimes we might be changing some of the language, and we will take a motion to amend, as stated. And that's verbal, right? And sometimes that's a little conceptual, and oftentimes members will say, I vote that I approve this, but I reserve the right, when I see the actual LTB language, to change or amend further. And I think that's probably the best way, if we have time to move forward, so that we don't have to have another meeting. The second option would be that if we don't get there, that perhaps we could have a shorter meeting before our October meeting to finalize our vote then. And but I'm not sure if our staff, if our consultants would be, if they have different advice.
Yeah, I think we're on a tight timeline, but Crystal, did you have a comment?
I would agree with you, Chair Kearns, that we are on a tight timeline. So having another meeting would be quite difficult. And so we'll just have to manage in this meeting, and then however we can continue the process outside of the meeting would be great.
Okay. All right, so we've talked about that, and we've moved on to the next, which is revise and update Nevada statutes. And you can see align Nevada revised statute and administrative code to promote access to treatment and preventative services. Resolve the conflict between the Good Samaritan Drug Overdose Act and drug-induced homicide law. Continue to update NRS to reflect the importance of public health interventions regarding harm reduction. Changes to NRS 453 were made in 2021 session to exclude the use of fentanyl and analog testing from the definition of drug paraphernalia, and provide immunity for individuals who in good faith support an individual in testing their drugs to identify toxins. And further policy changes could promote protections for harm reduction interventions to allow for the distribution and promote protection for persons who in good faith engage in harm reduction interventions. And one, I can't remember who this is attributed to, but one that we really liked from the last meeting was the harmonized criminal justice and public health responses to promote access to treatment and medical care. So a protocol would likely need to be established where public health can follow up on overdose events, which we've already discussed, the law enforcement component for investigation, and then provide information and resources to victims and or surviving friends and family members. So this hits a little bit on some of the other ones we've already talked about. Any thoughts from the committee? Christine, please go ahead.
I'm just wondering if that last point to harmonize criminal justice and public health responses could be put with the slides where we were discussing the verbiage of personnel. It kind of seems like it's the same group response and outreach. Is that something that could be moved into that previous slide?
I think it could be. Any other thoughts from the rest of the committee? Go ahead, Assemblywoman Toll.
I will say, and I can't remember who the original author was, but this is one of my, I think it was Gina actually. This is one of my favorite, sentences. So much so that it feels like almost a guiding principle for our focus on how do we strike the balance between public health and criminal justice, and between treatment and enforcement. and the types of things that we've been talking about. It is so broad that as a legislator or an agency in the states, it doesn't give any action item to take. So I would almost suggest that we take this as an introductory statement at the beginning of the report. Maybe at the beginning of the report in the section that leads to the work that the response committee has undertaken, or the SURG committee as a whole, but really more just a value of this group that we do seek to find that balance. But as a recommendation, I'm not sure that I would actually bullet point this out specifically, even though it's one of my favorite sentences on all the slides. I think rather having it as an overarching introductory principle instead of an actual recommendation.
Yeah, I think that's a great recommendation. So take it out from here, put it as our overarching kind of guiding principle for our report and our recommendations, which then would take us to the top 3, aligning NRS and administrative code to promote access to treatment and preventative services, and those 2 bullets underneath them. One of the comments, and I did have in the previous meeting, Dr. Carla Wagner and also committee member Lisa Lee discussed this from some of the research they had participated in. There are people who are not calling 911 for fear of being either arrested or the homicide, drug-induced homicide being attributed to them. And I know Christine, this sits on the ability of law enforcement to have some judgment in that, but I don't know if you have comments you'd like to make regarding this.
Well, like I mentioned earlier, the number of cases that are actually going forward for drug-induced homicide are pretty minimum, and they're looking for some pretty staunch proof that this person not only provided it, but knew full well that there was fentanyl or a fentanyl analog in it. It wasn't just, oh, I thought this was a prescription M30 and I just shared it with my friend. They're looking for those investigative leads like text messages and social media exchanges where it's quite clear that the person providing it knows what is in it.
Thank you for those comments, and that there have not been that many cases where this has been come up as an issue and have been prosecuted. You know, we, as noted, there was success with the change in the previous legislation on fentanyl test strips. In conversations I've had with some people throughout the state, there still is a feel that the fentanyl test strips are considered paraphernalia. So that may just become an education component as opposed to additional, because it is in our legislation already. Would there be any feel from the committee to go forth with something about resolving the conflict between the Good Sam drug overdose law and the drug-induced homicide law? Or have we hit that on some of the other items when we talk about the weights and the sentencing and those sorts of things, and that if someone's provided naloxone in good faith, they wouldn't be prosecuted? Thoughts from the committee? Assemblywoman Tolles, please. You're still muted.
There we go. I know we had a presentation on this that was excellent and certainly brought up a lot of good questions. And I think that's where I stand today, is that I still have some questions about exactly how this works. And I certainly understand the need. But I think that there's some challenges when we start to look at, for example, we know that there's people who don't call. and out of fear. So then the question is, then do you have some sort of public campaign to let them know? And then does that then get used by certain individuals as a loophole? Who are trafficking or selling or responsible for overdose deaths. And I think there's just and these are just questions that if I have on the top of my head, the public's going to have on the top of their head. And I think that there needs to be a little bit more fleshing out before I would feel comfortable with voting that, yes, I feel like we've answered all those questions to those complexities adequately to say we are BDR ready to move forward. And I say that knowing that there is some urgency among stakeholders that we want to resolve it right now. But I just feel like this is one that we need to unpack a little bit more because of some of the complexity and contradictions and how there may be unintended consequences on either side of the equation. So that's where I am currently, is that this would be a for further review.
Okay.
Important, prioritized, but needs further review.
Thank you for those comments, Dr. Woodard.
Thank you, Chair. Stephanie Woodard for the record. I would agree. I don't know if we have enough specificity right now to really understand exactly what we would need to change in either or both existing laws to help to resolve that conflict. But I do also want to underscore the sense of urgency that has been expressed in the presentations, that there is clearly something that is occurring at the community level with individuals who use drugs that has sort of cast some fear and doubt around the implications for calling when they have witnessed an overdose and the protections under the Good Samaritan Drug Overdose Act. I'm also wondering if there aren't some other potentially more immediate actions that could be taken while we do further analysis, including potentially preparing additional information and resources that can be disseminated to individuals around their rights and what the protections specifically are under the Good Samaritan law, as well as potentially some additional training for law enforcement. Dr. Kearns, I know you have done some of that training, and some of our other law enforcement agencies have taken up training around what really the protections are under the Good Samaritan Act. But we do have some practices that continue to occur throughout the state that really do call into question whether or not people are really accessing the full level of protections under the Good Sam laws currently. So I think it's both. I think we have an opportunity potentially to look at revising this recommendation to perhaps provide some more immediate action, as well as then continuing with the recommendation as it stands for further analysis.
Thank you both for your comments. I agree, because I know when the discussions were first brought up about this, it was, is it an education issue? Which I think that might be the immediate action, is both public campaign and with law enforcement. And then the longer term, looking at language for a further review on this. Any other comments from the committee on this recommendation? Okay, hearing none, we'll move. Oh, go ahead.
Sorry, Josh, can I just ask a clarifying question? So at this point, the recommendation is to put that under for further review, or are we revising it to say something more about education?
I think it's for further review to look at resolve the conflict between the Good Samaritan Drug Overdose Act and the drug-induced homicide law, but also to make the recommendation that in the near term, we should recommend education, public education campaigns, and also additional education and training for law enforcement on the Good Samaritan Drug Overdose Act. Is that correct, committee members? Would you agree? So it's kind of a two-part, I think, Crystal. Go ahead, Assemblywoman Tolles.
So I heard the recommendation for things for education as something that didn't necessarily need to be a formal recommendation, but that is something that there could be action that's taken currently to do a better job educating, doing training with law enforcement, as well as educating the public. I think the only thing that gives me pause is when we start to do like large public campaigns, that's where we might have unintended consequences of people looking for ways to exploit that, or people feeling like it's sending a message they're encouraging, encouraging or endorsing use from a public perspective. I just think that that's where it gets a little bit, it can get a little sticky. And so I think that's where we need to have further discussion.
Okay. And I do believe, Dr. Woodard, I would rely on you. There are some other programs in the state that are looking at public education campaigns, even to the level of specific populations that we're seeing increases in overdoses. And so that might fall within some of the existing programs that are out there. Dr. Woodard, do you have any additional information?
Yeah, thank you, Chair. Stephanie Woodard for the record. We do have several grants that have allocated funds specifically for different public messaging campaigns. I will say that as part of the overdose education and naloxone distribution, there is information provided on the Good Samaritan law. We do know from quite a bit of evidence that those protections under the law do have encouraged individuals to call when an individual that they are using drugs with is in distress and potentially experiencing an overdose. I think the goal here is that we've seen that there's been some chilling effects on individuals' willingness to call first responders when witnessing an overdose, specifically because of fear of some of the drug-induced homicide laws and potentially investigations. And so I do think that potentially strategic messaging around the Good Samaritan law would be warranted. And I do hear your concerns, Assemblywoman Tolles, around messaging and how it can be misinterpreted as endorsement. And what I would say is there's really good information out there on what a good public messaging campaign should look like, in addition to evidence to suggest that harm reduction strategies, including overdose education and naloxone distribution, have not provided evidence that they actually increase substance use in populations. And so I think making sure that all of that information is available to the public would be beneficial.
So then, if I'm correct in my understanding, we would put the recommendation for the resolve the conflict as a needs further review, and then do some outreach with some of the existing programs on the public messaging. Does that answer your question, Crystal? Okay, moving on to the next recommendation.
Sorry, Chair Kern, will we move to the next slide? Or do we
Yes.
need further discussion on the continue NRS?
I thought we were good. Does anyone want further discussion, or are we good with putting the conflict, resolve the conflict as needs further review, and then just doing outreach to the other programs that are already doing public messaging? I don't see any other discussion. Okay, now that we've moved on, and you guys get to hear my dogs now barking in the background, is to establish a pre-arrest deflection team that enables law enforcement, and these are criminal justice, sorry, that enables law enforcement officers working with community providings to providers to divert eligible individuals away from the criminal justice system and into community-based behavioral health interventions and social services when appropriate. Modernize Nevada civil protection custody laws to ensure that standards of care are followed and do not contribute to dangerous acute episodes of detox, withdrawal management without necessary linkage to follow-up care, recovery support, or formal treatment, and offer for medication for opioid use disorder, alcohol use disorder, and then reform criminal justice services to offer all 3 FDA-approved medications for opiate users and implement follow-up and referral with linkage of care involving the use of peer and other harm reduction strategies with reduced criminalization and punitive practices toward individuals with OUD. As I read these, I kind of see some intersection with what we previously talked with the outreach teams. I know this is specific to law enforcement and pre-arrest deflection. So I would like to get some thoughts from the committee members. Do these need to be separate or specific ones pulled out from this one? And have we covered some of this in the prior outreach support teams? Shayla, please go ahead.
Shayla Holmes for the record. I would see a good portion, I think, of the heart of what the first bullet's getting at with the outreach teams. I also think, similar to the previous conversation about just educating, like the Good Samaritan laws, I think we could enhance perhaps like our crisis intervention team training. I think that is absolutely focused on educating law enforcement on eligible services to help deflect. I think these things are in place, and perhaps it's just an increased education coupled with that outreach we already discussed.
Thank you for those comments. So that was in reference to the first bullet point on this slide. The other ones, I think, speak more to once someone has entered the criminal justice system. So looking at the issue of forced detoxification and withdrawal management, and then ensuring that our criminal justice services offer all 3 FDA-approved medications. So thoughts, Dr. Woodard?
Thank you, Chair. Stephanie Woodard for the record. Wanted to go back to bullet point number 1. There is model legislation on establishing statutory authority to allow for pre-arrest deflection programs. I do think that when we have looked at expanding pre-arrest deflection programs across the state, there have been some concerns with law enforcement agencies really wanting to ensure that there are some guidelines and that we are using best practices to identify individuals based on risks, needs, and responsivity, so that we know how and who to deflect from the criminal justice system and under what circumstances, and under what circumstances would law enforcement really be needed to take action. And so I do see this as well somewhat related to the overdose response teams that we had discussed previously, that this is separate and distinct and much more broad. Because the pre-arrest deflection programs work for individuals with both substance use disorder and mental health disorder, or one or the other, and really do offer an opportunity for community level, street level intervention for law enforcement officers to deflect. But I think what we have heard consistently is that the laws in many ways are still relatively silent. And that law enforcement organizations would be much more willing to entertain street-based deflection programs if there was some kind of expressed authority. So that is that's one of the rationale for putting forward that recommendation. And then if I can move down to bullet number 3, I do have some questions and concerns around the consolidation of this recommendation, because I see the 2 issues actually being somewhat separate and distinct. And maybe it's just that we need some additional punctuation in here to make clear that they're two concepts under the same recommendation. But wanting to ensure that we have all 3 FDA-approved medications available for individuals interfacing with the criminal justice system, specifically those that are incarcerated. This was actually put forward as a BDR concept by the Interim Joint Committee on Health and Human Services just in August. So I don't know if that has any implications for this committee and their considerations of this recommendation. But there is then also that separate part where it talks about the use of peers and harm reduction strategies with reduced criminalization and punitive practices towards individuals with OUD. I think there's a lot of lack of specificity really in that portion of the recommendation, which I think complicates, at least for me, how I'm conceptualizing this recommendation.
Thank you for those comments. I think it's important, first of all, the model legislation for the deflection programs and keeping that distinct from the outreach response team that we discussed earlier. Any other thoughts on these two? I know I have often heard some people think withdrawal is treatment, and withdrawal is certainly not treatment. So to your point about making the distinction between those two, being the second and third bullet becomes important. Other thoughts? Christine, do you have any thoughts on this from a law enforcement perspective? And before that, we'll go to Shayla.
Just that
I just wanted to,
sorry, is that me? This
Go
Christine.
ahead, Christine, and then we'll go to Shayla.
Just that I agree with Dr. Woodard's comments on the way to approach that.
Shayla, please go ahead.
Shayla Holmes for the record. I would just want to encourage that maybe we have reform and fund criminal justice services to offer all 3 FDA-approved medications. I know in working with my local jail, some concerns why we don't offer medication-assisted treatment as is the cost. So I think that offering some funding to do that at the local level would be important.
Thank you for those comments. Dr. Woodard, did I understand you said that another committee was taking forth the third bullet point?
Stephanie Woodard, for the record, the first half of the first bullet point. So ensuring that individuals have access to all 3 FDA-approved medications for the treatment of opioid use disorder. So that portion has been undertaken by a BDR that they work sessioned in the Interim Joint Committee for Health and Human Services.
My question would be, is it still possible to provide recommendation to that committee to include the use of peers and other harm reduction strategies?
So Stephanie Woodard, for the record, that's the portion of this recommendation that I'm struggling with, just because there are a lot more questions, I think, than answers. It's kind of overly broad, and I'm not exactly sure how the two necessarily fit together. So certainly follow up with linkage and referral to care makes sense, but I'm not exactly sure what reduced criminalization and punitive practices towards individuals with OUD actually means. And so I guess I would have more questions than answers. I see these two as actually, I know they've been consolidated, but I'm not seeing their consolidation is something that I can make sense of.
Crystal, were these were two separate that we consolidated, and who made the recommendation?
The FDA approved medications recommendation was made by Dr. Woodard, I believe. And let me find the other one.
And while she's looking at that, I wondered the second part of this. to me, that kind of goes with what we talked about in the previous with those outreach support teams and ensuring there's, follow-up, linkage to care, harm reduction to individuals coming out of institutions that have either had an overdose, a suspected overdose, or I think the other piece is those that are coming out of facilities where they've been incarcerated, as well as that linkage to care.
I would just add that the last part of this actually was pulled from a presentation made at the interim health committee. So it was not a specific recommendation made for the purposes of this subcommittee.
So having said that, would the committee feel comfortable with us supporting the Reform for Criminal Justice Services for the 3 FDA-approved medications and taking out the last part of this and just making sure that we have the use of peers and harm reduction and follow-up with linkage to care as the outreach support component that we talked about already?
So Stephanie Woodard, for the record, I view some of the language in here. I would agree with you, Chair, that makes sense to me. I would also just point to the reduced for criminalization and punitive practices towards individuals with OUD, really almost being like a second layer of the goal that, or the recommendation that we had seen earlier around harmonizing public health and law enforcement. So I feel like there's lack of specificity here, but I do think that it definitely still is something that is important that we would want to include. So perhaps there's an opportunity to include this kind of language as kind of even more granular level to the guiding principle that we had talked to before, and so that we don't necessarily lose it and that it's included in the language that we put forward in our recommendations.
Thank you. I think that's a good course of action to take and a good recommendation. Any other thoughts or comments on this? Okay, hearing none and trying to be respectful of everyone's time, we can move on to the next. So this was a increase state funding for substance use treatment facility beds on a grants basis. This can aid in the research regarding the impact of having treatment available on the economy. I think this was brought forth by Gina. If I remember correctly, Gina is not with us today in the meeting. So if anyone has any thoughts.
I'm here.
Oh, okay, great.
Yeah, I apologize for being late. Yes, this was just in response to the idea that we need beds, and I know that's just a universal complaint that we need beds, and it was just a stab at seeing if there was something we could do.
I would ask Dr. Woodard, are there any other programs that are looking at bed availability for treatment?
Yes, thank you, Chair. Stephanie Woodard for the record. So the Support Act grant that we had, the planning grant we had through the Division of Healthcare Finance and Policy, identified the need for additional access to residential treatment as well as community-based withdrawal management. And so we have put forward to CMS an 1115 demonstration waiver application that is currently under negotiations with CMS. Under that waiver, what will be allowed is to bring in Medicaid reimbursement specifically for residential treatment and community-based withdrawal management services, as well as crisis residential treatment services. And we are really seeing this as an opportunity to really meet the goal of this recommendation, which is to ensure that we have greater access to residential treatment beds. Currently, we're incredibly limited because the only funding that we have available in the state for residential treatment and community-based withdrawal management services is through our federal substance abuse treatment and prevention block grant. And the allocation of those funds has gone for many years, specifically to meet the needs of residential treatment beds. So by moving forward with the 1115 demonstration waiver, we will open up a whole other revenue stream for those providers that are providing residential treatment and community-based withdrawal management. So there's hope on the horizon. We are anticipating that that plan will be approved through CMS. The last I heard from our state Medicaid agency is January of 2023. And then there will be an additional year needed to go towards full implementation. But that should then free up some of the federal grant funds that we have singularly providing funding for the residential treatment facilities to be able to diversify that funding and expand to a greater number of beds.
Gina, does that address some of what you were trying to get at, or do we need to?
That's perfect. We can withdraw this if necessary.
Other comment from any committee members, or are we good with withdrawing this, given the fact of what Dr. Woodard just provided, that it is something that's being addressed through other grant funding? Okay, seeing no comment, we'll move on to the next slide. These were priority recommendations of other. They didn't really fall within. First is support funding decisions that increase funds to evidence-based programs that strengthen and educate families, such as increasing and expanding maternal, infant, early childhood home visit programs within the state. A policy change to cover non-pharmacological or complementary treatment for pain, also to increase coverage of preventative and non-pharm CAM modalities. Establish a user-oriented searchable website for programs on prevention, treatment and recovery and response for all. I had a couple of thoughts on these, but I would also look for any comments or questions from the committee members first. Dr. Woodard, go ahead.
Stephanie Woodard for the record. So I had some questions on some of the priorities here. The first is the policy change to cover non-pharmacological or complementary treatments for pain and increase coverage for preventative and non-pharmacological or CAM modalities. My question was, are we looking to expand this specifically within our state Medicaid plan? Or are we looking to look for these services to be available across all insurers in the state? And would that be done through legislation? And then the second is really more of a comment. So the user-oriented searchable website for programs on prevention, treatment, and recovery and response for all substances. We do have a website, Behavioral Health NV, and that does have a repository of all of our state certified programs, as well as location. It can be searched by level of care, geographic location, or adult or adolescent services. So I would recommend that potentially this recommendation be reformulated so that that existing website, in addition to 211, may be optimized to meet the goal here, as opposed to establishing a new website for the same purpose.
Thank you for that recommendation, Dr. Woodard. I just want to, Shayla, I'll let you speak in just a second. I just want to say we're at 2:31 by my watch. So if committee members can stay on for an additional maybe 10 minutes, we can probably get through this. Go ahead, Shayla.
I was just going to say, we had discussion earlier about the maternal, infant, early childhood home visiting programs. And I just wanted to throw that out there, as far, like we started with those as far as new recommendations. The policy change to cover non-pharmacological and complementary treatments for pain was a recommendation that I had made. And I would hope that that could be not just changed to Medicaid, but to insurance policies overall, as I think the more individuals that have access to those types of supports, the less prescription writing we may see, or
the reduced behavior of for needs for substances would be, increased.
Dr. Woodard, did you have another question or comment? Oh, okay. My question was too on some of these, should they be under the response or should they be under one of the other committees such as prevention? I think, covering non-pharmacological and the other is important and something that we should be looking at, but I just didn't know if that should come out of the response subcommittee or perhaps a recommendation to one of the other committees such as prevention. Christine, go ahead.
I would agree with you on that, Terry, that it probably doesn't really fit under our response committee responsibilities, more so treatment and or prevention.
Thanks, Christine. Assemblywoman Tolles. I
think that I'd like to see this continue in the discussion because I think it's valuable for the policy change for non-pharmacological. So maybe we could put this as for further discussion and address it in October and to see if it falls in line with one of the other groups, or perhaps they already have a recommendation that deals with this. But I'd like to see it not disappear. And then as far as they establish a user-oriented searchable website, that was my recommendation. And I concur with Dr. Woodard's statement that what we have existing, if we can just enhance public engagement and promote it more so that we see, the public know exactly where to go and find that and use it.
Okay, I think that Dr. Woodard has to go. She has another commitment, but if we still have enough committee members for quorum, which I believe we did because Gina Flores O'Toole joined us. Is that correct, Crystal? Okay.
That's correct.
So it sounds like on this one, we're going to put policy change for the non-pharmacological as needs further review and look at if there's that recommendation coming from any of the others. We will support the user-oriented searchable websites for programs on intervention. And then we had previously discussed the early childhood home visiting programs within the state. So Crystal, do you have some changes in the language that you can put up so we can look at that?
I do. Let me click forward here. And this is revised recommendations with next steps. So starting from the beginning, and I think there still might be wordsmithing, so I'll let you take it away, Chair Kearns, but I do have all of them that we have talked about and that we have reworded, as well as those that are for further review.
Okay, and you said there were 5, is that correct?
Yes, we did end up with 5. So you see 2 here on this slide and 3 on the next, and then the following slide just has some notes about how we wanted to create a overarching principle around harmonizing criminal justice, and then it also has 2 of ours that we noted for further review. So the next, this slide and the slide after it are the recommendations that we would be asking the committee to agree to put forward to the larger SURG.
Okay, so the first is support legislation to establish a statewide and regional overdose fatality review committee and recommend an allocation of funding to support the OFR to effectively identify system gaps and innovative community-specific overdose prevention and intervention strategies in accordance with established best practices. Looking at the ORF toolkit is what it's called. And then Christine would provide research and possible revisions to include the medical examiner.
And actually, I'm going to take that part off of there. Sorry, Dr. Kearns, because I think we decided the medical examiner fit in a different area.
Yeah, you're correct. That is correct. Then the next, go ahead. Oh, so then the next one is Suggested revision is revised penalties based on the quantity of fentanyl, analogs, or other synthetic drugs of high potency that are trafficked. And we would review language with the Board of Pharmacy for accuracy as well. We'll go to the next slide. Leverage existing programs and funding to develop outreach response providers and or personnel that can respond to any suspected overdose and offer follow-up support, referrals, and services to the individual and loved ones following an overdose. Provider or providers and or personnel to be deployed to anyone being released from an institutional setting who is being discharged post-overdose or suspected overdose. Fund personnel and resources to investigate and prosecute drug-related crimes, including an independent medical examiner for reports that specify the cause of death in overdose cases where the source of the drug supply has been identified and can be prosecuted. And the last one was reform and fund criminal justice services to offer all 3 FDA-approved medications for the treatment of opioid users. Didn't Dr. Woodard say that that was being taken up by the Health and Human Services Committee?
She did. So that one is one we could remove. I wasn't sure if based on that, it was something that you wanted to remove or add in support for it, or however that might be approached.
Okay, and we can talk about that. Do you want to go to the next slide? Sorry, I'm kind of hurrying through trying to get this. And our report will have as a overarching guiding principle, harmonize criminal justice and public health resources to promote access to treatment and medical care to reduce criminalization and punitive practices towards individuals with SUD. And then we'll further review the conflict between the Good Sam Drug Overdose Act and the drug-induced homicide. But the immediate action would include recommending community level education, using best practices, as well as education for law enforcement. So we would reach out to those that are already doing that and provide our support. And then policy change to cover non-pharmacological or complementary treatments for pain, also to increase coverage of preventative and non-pharm CAM modalities is a further review. Oh, is that it, Crystal?
That is it.
Okay, so do you want to go back, just go back to the beginning of those 3 slides? Anyone like to make comment or have questions if we move these forward as our recommendations from the committee?
Chair, I just want to get a count of how many we have ended up with. I think we're in the target range, but we have 2 main ones on this slide. How many on the next slide?
I think there were 3 on the next. Oh, 2 actually, because we were going to take that. Or do we want to take the reform and fund criminal justice services to offer all 3 FDA approved, as opposed to supporting the interim standing joint committee on HHS's BDR they are drafting on this? Thoughts from the committee?
Well, we haven't quite addressed what we'll do overall as a committee in terms of supporting other recommendations. But I think that maybe we should take it off as one of the recommendations for now, and then make note of it in our SURG committee as a whole, that this would be one that we support an existing effort. And if there are enough of those, that we could perhaps find a way to either include that in the report or just have it on the record in our meeting.
Okay, I think that's a good path forward.
So that puts us at 4 so far.
Yeah.
2 on the first slide, 2 on this slide.
That's correct.
And then the next slide.
I think on the next slide was the for further review. Adding that overarching guiding principle in our report. And then for further review was the conflict for the Good Sam and drug induced. But we could reach out to other entities that are doing the community level public messaging, and also for the adding into the CIT training on the Good Sam law. And then for further review for the policy change to cover non-pharmacological or complementary treatments for pain. So it looks like we have 4 recommendations, and the others are for further review or to provide to outreach to other areas that are already working on these.
Okay, great, thanks. And we did include the fentanyl penalties or the opioid related, that was on the first slide.
Can you go back, Crystal?
I've now put all 4 on this slide, so I know it's a lot to read at once, but this is the final 4 as they stand now.
Yeah, it looks like that's the second one about the revising the penalties.
Great. So we've got 4 recommendations plus 2 for further review and a note of support to an existing recommendation. Fantastic.
That's correct.
And what I would just add is we may have some slight revisions by committee members prior to our presentation at October 3rd, just for if we get additional information where we were looking, or if there might be some wordsmithing, I guess is the word I'm looking for. So at this point, committee members, are you good with those recommendations?
Yes.
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 Do we need to make a motion that will move these forward as our recommendations?
I'll make that motion that we move forward with elevating these 4 recommendations, the 2 additional recommendations for future consideration, and the expressed support of the existing effort for the final point to discuss in our October SURG committee as a whole.
Would anyone like to second that?
Christine Payson for the record.
Mr. Sayla,
Thank you. So we have Jill Tolles, who made the recommendation, the motion to move these forward, and then Christine Patient, I heard first as a second. Okay, next slide. We'll move on. If we still have any members of the public with us, we'll open it back up for public comment, keeping in mind that it's limited 3 minutes per person, and no action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. Crystal, do you see anyone for public comment?
I do not.
Okay, I was going to give it just a minute longer to see if anyone was trying to unmute or raise their hand or anything. Okay, I personally want to thank everyone for staying on this extra 16 minutes so that we could get through this. And at this point, we will adjourn the response subcommittee meeting. Thank you all.
Excellent work, everyone. This was a long time coming, so thank you.
Yes, thanks, everyone.
Thanks to Crystal for amazing prep work on this.
All right, look good to me. Thank you, everybody.
Thanks, Joel. We appreciate your input.
My pleasure.